history. So no, I was going to, again, try to cram like 2 topics into one, but in reality, the topic of women's health covers 6% of the exam, but it's loosely defined, so it's not just gynecologic care, but it also sort of applies to how different diseases present specifically in women, or how they're more common in women. For example, something like rheumatoid arthritis or lupus, or the different manifestations and presentations of coronary disease in women and things like that. So I won't be offended if you don't take me very seriously, because I'm not an expert in this, but I tried to distill down everything I could as much as possible and stick to high-yield things that I didn't know very well and not rehash things that you guys know in and out. So I started with the ABIM blueprints again, and kind of looking at our scores on the in-training exams. I went through the MIXAP syllabus, and I pulled out topics from ACP Smart Medicine, which is sort of like the ACP up-to-date, and then went to the guidelines and actually read a lot more obstetrics and gynecology journal articles than I think I ever have in my life in preparation for this. So, are you a little happier now, Kate, or is it? So, Kate, how do you diagnose menopause? I'm going to try to make this pretty interactive. I'm not picking on you. How do you guys diagnose menopause? Symptoms and clinical history, right. What's the median age that it comes on at? 51. You want to give this? All right, perfect. It's all clinical. So if there was no clinical history, or let's say somebody goes into menopause at age 42, what biochemical test would confirm it? Is menopause? Is it high or low? All right, good. That's all there is to it. So high FSH with a low estradiol is sort of the hallmark of it biochemically. In younger women with amenorrhea or oligomenorrhea, you should do your typical secondary amenorrhea workup, which would be like TSH and prolactin. Something that's, like they like to put in these board review stuff is that if people have a high burden of autoimmune endocrinopathies like Hashimoto's thyroiditis and Addison's, the diagnostic entity they want you to think about is premature ovarian failure. But you would test for that with the FSH and estradiol as well. All right, so we're just going to talk about really simple stuff. Most effective treatment of vasomotor symptoms, hormonal therapy. Other options, SSRIs, anything else? Nope, doesn't work. What else? So I don't know, this is, I guess, both clinically relevant. I don't know if they would give you something on the boards, but other options are gabapentin and clonidine, which these are all considered slightly less effective than hormonal therapy. But gabapentin actually may be even more effective than SSRIs as well. So something to think about, particularly if they have somebody would have like a contraindication to an SSRI or is already on one or something and has hot flashes on the boards. So in terms of hormonal therapy, it's preferred to give combo. You guys all know why. I won't even ask you. Progestin alone is actually an option if somebody has like an absolute contraindication to estrogen. It's not as effective as estrogen-containing combinations. The general rule that you guys know is to go with the lowest dose for the shortest period of time. There's no real specific evidence that low dose is compared to standard dose, but it's thought to be less effective. And many women will have rebound symptoms. So that gets to the point of when to stop. There are no hard age cutoffs, and all the guidelines tell you to individualize, but there are some common rules they ask you to adhere by. So what age would start to make you guys nervous about continuing hormonal therapy for people? 60, 65, good. And how long, how many years would you be comfortable, like if your clinic patient's been on hormonal therapy or on the boards? 5 years? Good. So you guys either know this or are guessing well, so that's about right. So the guidelines say that the risks are higher in 60-year-old folks and higher, and the goal is to not exceed 3 to 5 years of hormonal treatment. You guys know this stuff, so I won't ask about this. This is sort of old news. The stuff on CVA risk are somewhat marginal. On the cardiovascular disease, the jury really is still out despite all the meta-analyses and things like that. Lung cancer is a really complicated story with hormonal therapy, but there is one big bottom line, and that is to always avoid it in cancer survivors. Sorry, this little pearl ended up taking over the screen, but I put this together this morning. But I did read a lot this weekend. So, but the main thing is that, whether irrespective of the risk, the hard and fast rule that appears in both the North American Menopause Society guidelines as well as ACOG guidelines is to avoid it in patients with a personal history of breast cancer. Anything new you guys have heard so far, or is this all old news? All right, any other reasons to give hormonal therapy besides hot flashes in menopause? Bone protection, good. So that's really anything else? Okay, good. How about sexual health? Depression? Urinary incontinence? Can I sell anybody any of that stuff? So there's actually a lack of evidence for some of this other stuff. It's not meant to be routinely used for sexual health. That is also for boosting mood, depression, things like that. So it's not meant as a treatment for that. So don't choose that on the boards. It has a minimal benefit in urinary incontinence. And in most situations, you should not be prescribing it for that indication as well. But as Jen mentioned, it is important for bone health. And the major group, again, this is sort of a very endo-specific recommendation, but in younger folks, particularly those that have had like premature ovarian failure, it is recommended that you give them hormonal therapy, or at least you consider it, especially if they have osteoporosis or a lot of risk factors for it. So that would be like another pearl I would put in my mind that aside from just treating hot flashes, somebody with really high risk for bone disease or with osteoporosis at a young age who has gone through menopause or has had a hysterectomy and oophorectomy, to give them hormonal therapy, which was news to me. So questions or thoughts on that? Too fast, too slow? Just right? Just right.
Not interesting.
What? No, be honest. Not interesting?
I mean, no, it's not.
I'm sorry.
It's not your fault.
I know, that's not my fault. Thank you. All right, so non-hormonal therapy, thought to be less effective. I don't think they would make you choose an SSRI in the boards. The only one that has FDA approval is paroxetine, but venlafaxine and venlafaxine and sertraline, all of these things have trial data to support their use. As I said, gabapentin is really good. Clonidine too, so you don't really have to worry about the concerns with blood pressure, so I think that would be sort of an obscure question on the boards, but if somebody has, is normotensive or sort of marginally, normotensive, it does not have a major blood pressure effect at like the 0.1 milligram dose twice a day. And then there is really no evidence at all, and the guidelines really, there's not like any room for error, at least in the guidelines. Herbals, vitamins, acupuncture, exercise, none of these things work for menopause. So, all right. Julian, you know all about this. So, basically the options here are topical or oral. No, I'm not joking about that. He seems to know everything about this, so maybe I should just let you do it. No, so just the main point here is that even though topical estrogens are not very systemically absorbed, the guidelines still recommend against their use in patients that have a personal history of breast cancer. So this, again, is just the main teaching point for estrogen-containing things, that if anybody has any history of it, even though the risk is probably really, really low, maybe if you go to Susan Hong's clinic, she is using this, but for test-taking purposes, you would not want to be using even topical estrogen for people that have a personal history. Good. So menopause, we're done with it. Don't worry. We're going to move quickly through a lot of this stuff. So basically, it's a clinical diagnosis, unless, I guess that should be ellipsis, unless there are specific things that make you want to get biochemical testing. And hormonal therapy, we've talked all about for moderate to severe cases of the most troubling symptoms, which are hot flashes and atrophic vaginitis. Any other thoughts on that? Moving along. So this gets really complicated for me, so I try to simplify this into 6 slides for what could they test you on, and how do you break it down? So what are the options for screening? Pap smears, how often if you just do pap smears? 3 years. And with HPV? 5 years, good. So remember, HPV is not routinely done in the 21 to 30 population. There is some role for reflex testing at 25 and up, but you should only use cytology for the 21 to 30 block. So, when I start thinking about this and I get these in clinic or when you've been in women's care and you're like, what do I do with ASCUS? What do I do with LSIL? I think it gets really murky. So the most recent iteration in 2013 kind of made everything very simple. And if you just remember that HPV is really, really emphasized in all these guidelines, that we know HPV is the cause of this. It's crucial for oncogenesis, and the PCR is the crux of all decisions in women over the age of 25. You'll be fine. So, if HPV is positive, then you start getting worried. If HPV is negative, then you don't have to worry as much, and you can usually just retest in 1 to 3 years. So if you remember nothing else and you start to panic on the boards, just remember that HPV testing is really sensitive and really specific and really important for knowing if this is an oncogenic lesion or not. All right, so how about a normal cytology in a 35-year-old woman with HPV positivity? What would you guys do? What's that? Yeah, so if it's HPV positive, it's sort of higher risk. What would your gut tell you? Repeat in a year. Perfect. So you repeat in 1 year. And then if it's persistently positive, particularly with the high-risk serotypes, then they get colposcopy.
When you do it, the first time you do it, does it stereotype?
It does not. This is like a 9-tree decision point thing for normal cytology with HPV, but I think it gets really like complicated after this. So I think I'm trying to like hit what I guess you should know.
If you positive, you don't stereotype,
You
you just repeat in the year.
repeat in a year, and if HPV is persistently positive, they can serotype it, and if it's high risk, then you can go straight to colposcopy based on that. I'm just trying to tell you like what I learned and trying to simplify these things. Like, you know, I'm not here to give a pap smear lecture. I'm just trying to give you so hopefully it's not like too dumbed down, but still helpful. Ask us in a 26-year-old, what would you think? So you would do HPV reflex testing. That's the appropriate age group, and if it's positive, repeat. So if it's negative, you can just go to co-test in 3 years. But if it's positive, you actually go to colposcopy. So again, the new guidelines continue to emphasize that HPV makes us really worried, and you kind of jump to colposcopy a little bit more than you might have thought or you might have learned in your OBGYN rotations 3 to 5 years ago. All right, how about low-grade squamous intraepithelial lesion? So the answer is always going to get HPV reflex testing. So what if HPV is positive? Colposcopy. Good. It's basically the same. The only difference here between ASCUS and low-grade squamous lesions are to co-test in a year rather than 3. But I think this gets really nitpicky. I think the main point that they would try to emphasize on a board question would be like, when do you need to refer for colposcopy? And this would be another reason. And how about high grade? Straight to colposcopy? Does HPV matter? Yes? No? Doesn't. So you don't actually need to know what the HPV is. If they have a high-grade squamous intraepithelial lesion, then you go straight to colposcopy or even a LEEP. So basically, what I take home from this, and again, like it gets really murky, you're always going to pull it up on UpToDate in clinic if you're not sure, or the path report might even tell you. But for these intermediate cytology lesions, you ask us in low-grade squamous intraepithelial lesion, you want to get the reflex testing. And if it's negative, it can wait, but if it's positive, you go to colposcopy. So basically, the bottom line is if HPV is persistently positive or you have a high-risk cytology, you're always going to choose colposcopy on the boards. That's the really simplified 5-minute version of working up abnormal pap smears. And maybe clinically practical as well. Slowly losing everyone? Not yet. All right, colposcopy as well. Someone need to say that? Any questions on any of that? I mean, I did some more reading, but I'd have to probably pull up the algorithms myself if you guys have a very specific question. The 21 to 25 age group gets really difficult as well, so I think that would sort of be a really challenging question that I wouldn't study for. I don't know, she's happy in every picture.
Any of these change when
At least at this point, it's going to evolve, but this is the most recent iteration of the guidelines, which have been endorsed by all the societies, and we still live in an era where not everybody was vaccinated. So it'll probably evolve over time. This is always going to be very, timely. So at least this, maybe 2 years from now, we're going to be talking about something different. But I mean, in terms of what I think would be testable would be when do you need to refer to colposcopy? And I just remember these rules: persistently positive HPV and really high risky lesions. All right, so first the good news on this. So you guys probably start thinking about menorrhagia and metrorrhagia and can't remember them and keep them straight. So the obstetricians and gynecologists want to phase these terms out, and now they're just subclassifying it as heavy or intermenstrual. Yeah, so you don't have to worry meno or metro and try to keep that all straight. It's the best news I can give you. The other piece of news I can give you, this is like the good time to cheer you all up, is that 24-hour telemetry renewal is going to not be a problem in this hospital anymore. So I take small credit for that, but it took a lot of fed-up nursing managers as well. But that should be coming at some point soon as well. All right. I just spent all my positive energy here, so hang with me for another 15 to 20 minutes. So, but I guess the bottom line, so the thing is they have all these complicated things. So they've made it simpler here, and they've made it more complicated in the back end. And I'm not going to go into this as well. When would you test somebody for a clotting disorder? Like, what are some of the red flags that would make you think about whether somebody needs like a coagula or a clotting disorder workup? What's that? Clot. Okay. Let's say it's like a 28-year-old woman they give you on the boards, and she's complaining of heavy menstrual bleeding. Anything else you want to look for in the history? Bleeding elsewhere, family history. And there's one other clue I think would be like a buzzword for the STEM, which would be heavy bleeding since menarche. So it's possible that these patients can go, there's enough literature out there that these patients can go for years without being diagnosed with something like von Willebrand's disease. But one of the main clues is that the periods have always been heavy since menarche. And then some of the other things that they would probably pepper the question with if they wanted you thinking that way. What's the first screening test for von Willebrand's disease since we're here? Any thoughts? It's actually going to start with the PTT. Because remember, von Willebrand factor and factor VIII travel together, so these patients are often factor VIII deficient as well, so the PTT is almost universally prolonged. So this is sort of the basic coagulopathic workup. And then there's specialized von Willebrand testing after that. But I think if they prompted you and they didn't give you a PTT, that's the test you would order before you do specialized von Willebrand stuff. Causes are, there's no surprises here. Actually, there were a couple surprises. So, the main things in younger folks are things you guys are all familiar with: pregnancy, structural things. PCOS is a possibility as well. Patients can get heavy bleeding with the irregularity of their cycles. I don't know if this would come up, but I want to put it on there because it was news to me, and it's in the latest ACOG guidelines at least. That is to consider chlamydial testing if there's high risks. And I don't know how that correlates to uterine bleeding, but they ask that you consider that diagnosis as like a sign of a chronic pelvic inflammatory disease. And then the older people, I guess the main thing we all know to worry about is this endometrial hyperplasia and cancer. So what is your workup then? So let's say the CBC and all this stuff is normal. Heavy bleeding, what's the first step? What's the next step? So let's do it like pregnancy test is normal, TSH is normal, CBC is normal, coags are normal. Ultrasound. How about in a 45-year-old or higher? Do you think that you need a transvaginal ultrasound? Okay. Would it change it? Like, let's say in the boards you were pressed to choose transvaginal ultrasound or a hysteroscopy with biopsy. Yeah, so prioritize that. The guidelines actually tell you that there's not a need in this older group that you can proceed directly to endometrial biopsy because these folks are going to need one anyways. You can use a transvaginal ultrasound beforehand, and clinically we always do this, I think. But I will emphasize that if you were like push came to shove on the boards and you had to choose between one or the other, you guys would probably choose biopsy, and that would probably be the right answer, at least in my own opinion. And what if it's all negative, including the transvaginal ultrasound? Expectant management is usually, there's some other options for like hysteroscopy and intrauterine ultrasound as well. But I think that none of that would necessarily change management unless somebody has a big red flag. All right, questions on any of that stuff? Contraindications, OCPs, only one slide here. 5 of them, go. Smoking, over 35, right, go. Migraine with aura. Yes. Can hypertensive patients take oral contraceptives? Yes. Relatively contraindicated, are you okay? Yep. All right. Relatively contraindicated with end organ damage, so patients with CAD, previous stroke or CKD. The only other thing I put on here, because it actually is in some of the documents, and this is an internal medicine board test, is patients with lupus that have like more severe lupus, I'll say, with nephritis or APLA, should not get OCPs either. But I think you probably wouldn't be tempted to do that on the boards, or you would see that was a pretty obvious red flag. All right, good. Internal medicine problems in pregnancy. So what's safe to use for diabetes in pregnancy? What medicines? What anti-glycemic agents? Insulin, always a good choice. That's one of the first line options. But let's say somebody like can't use insulin or something. They shouldn't be having a baby. They shouldn't be allowed to take care of children. What's that? Yeah, so sulfonylureas are the second option as well. A couple other reminders. This is more clinically than board review, but I will put it in here anyways. Is to stop the ACE inhibitor that they're on for their nephropathy. They actually ask that you avoid statins during the pregnancy. I don't know what the teratogenic effects of that are, but it's advised to hold it for those 9 months. Sulfonylureas, insulin are all safe. Metformin is sort of a third choice, but it's probably safe. And then the other things are screenings up to date. All right, gestational diabetes. Any ideas? How do you diagnose it? 28 weeks glucose tolerance test. Just guess a glucose that you'd expect to see. 160, 120, 160 is a good ballpark. So think about 160, so it's 2 hours after the glucose load. Again, sulfonylureas are fine for milder cases. Otherwise, you should prefer insulin. Metformin is the third choice. In terms of, I think a lot of times the boards want to emphasize lifestyle management options as well. So I guess the things to know, we're not managing a lot of pregnant patients, but they actually are supposed to be calorie restricted and should not gain very much weight during pregnancy if they're obese and have diabetes. All right, how do you control blood pressure in pregnancy? So first, what are the blood pressures you guys are willing to live with in pregnancy? I didn't know this. Yeah, less than 160 is good. And what are their options? So hypothetically, if you were to be put on a med,
I'm not.
what are your medication options? You guys probably remember this, right? Labetalol, methyldopa. So yeah, hydralazine. Yeah, they actually. I learned that in med school, but they don't recommend that as one of the top 3. So good. So the considerations. I mean, they're gonna, if they want you to work up preeclampsia, then do that. But I think that would be more an obstetrics board examination. So I think that you'd assume that this was just a uncomplicated hypertension in pregnancy. We're generally more permissive than we're used to being. So the systolics are 150 to 160 are acceptable. Diastolics 100 to 110 are acceptable. And that's not only endorsed in ACOG, but it's also endorsed in the ACP Smart Medicine as well. So just a little bit more permissive, and the medicines you guys threw out are the first choices to use.
What is that first? Does this mean like the word OB? What is it?
Yeah, it's not. Yeah, I'm just saying I don't think that they would test you on preeclampsia management. I'd be surprised. Oh, refer to OB. I mean, that's what you do in real life. I mean, they're smart enough on the boards that they don't make you manage things that we don't routinely manage in practice. But they also, most of the board is set in the outpatient setting or the emergency room, so you do have to kind of know some of this stuff because they often put you in the emergency department on the ABIM. All right. Pregnant women, screen all of them for thyroid disease. What do you guys think, yay or nay? I thought so too. Believe it or not routinely recommended. I think it's part of their panel though. But it's not routinely recommended, so I don't know if there's how much choosing wisely type stuff there will be on the boards this year, but just know that that's out there. How about hyperthyroidism in pregnancy? Let it ride. Use the medicines to treat it. Treat it. You think it's safe to? Have to. You're right, exactly. So there might be some mild teratogenic effects with propylthyroid, I wouldn't say PTU or methimazole, but it's thought to be outweighed by the fact that, sorry, that got cut off, right? The risk is high. Yeah, I'm sorry. The risk of uncontrolled hyperthyroidism in pregnancy is.
Keep that up in the wrong spot.
I know, man. This is the worst presentation that I've ever given. So the other thing I will say is that you can't give iodine if somebody has refractory thyroid. That's endo stuff. Thyroidectomy is an option, but I think that's probably way too advanced. How about hypothyroidism in pregnancy? There's one pearl to know. Hopefully the pearl's not covering up the pearl.
Double up the.
Double the dose.
Something like that.
You got to go up on it. 25 to 50%. Good. And that's right at the beginning of pregnancy. So as soon as they find out they're pregnant, they have to go up on their dose because the fetal effects of being hypothyroid are felt most in the first trimester. Postpartum thyroiditis is pretty common, so they might give you something like that. It's just self-limited, so let it ride. All right. PE. in pregnancy. Okay to CTA or go to a VQ scan? Your gut tells you VQ. So this is weird, you know. So it's actually they're both considered about. So ACOG says they're considered equally safe, but your MixApp syllabus and the ACP Smart Medicine say to go with the VQ scan first because it's traditionally considered low risk. I don't think there's any data on that. So again, I think if push came to shove, you'd probably choose the VQ first on the exam, unless it was like so high probability that you just feel obligated to get the CTA. Low molecular weight heparin is preferred.
But you can do Coumadin. I did a mix-up question.
So we can do an aside on that. So when is warfarin thought to be most teratogenic? First trimester.
Yeah.
And what is like really the only entity that you should anticoagulate with warfarin in pregnancy?
Oh, API?
So that's one, but they can say you can do heparin with aspirin for that. Mechanical valves. So there was a mix-up either 15 or 16 about that as well. That after the first trimester, I don't think they put, because it's actually very controversial. I don't know if I put that in here. It's really controversial whether or not warfarin. I mean, the ACCP guidelines in 2008 say it's okay to do that for prosthetic valves, but ACOG is a little bit more wishy-washy on it and says to individualize the decision. So, what do you think about a personal history of one unprovoked DVT? What would you do for that patient? Let's say they're not on anticoagulation, but they become pregnant. Gut tells you guys are smart people, so what does your gut tell you about that?
God says no, but I think that's it. I think you do it.
Yeah, so clinically watched, so that's good. So they actually, so you can strongly consider prophylaxis, but so that would, I think, be too nuanced of a decision to test on the boards. But let's say they have one previous DVT with thrombophilia. You guys would all want to prophylax, right? So that prophylaxis is needed. And then if they've had multiple and for whatever reason are not already on it, they need to be prophylaxed as well. Potentially even treated presumptively, or preemptively, I should say. But prophylaxis for folks that have a history of unprovoked DVT and high-risk features. But again, you may not have known that, but you would have answered that correctly in the boards because you guys are smart people with good gut instincts. So, you are. So in diabetes, sulfonylureas and insulin, hypertension, be more permissive. You guys memorized the list of drugs that were safe when you did your third-year rotation, and those haven't changed. Thyroid disease, you guys know how to manage that. And low molecular weight heparin is the preferred choice. We're moving quickly. Good. Whom should we give? So this isn't controversial at all. This is a USPSTF level or grade B recommendation that we should be doing this. We don't do this often, but this is up there with like screening for AAA and a lot of the other stuff we do routinely in terms of level of evidence for it. So who gets chemoprophylaxis for breast cancer? What age do you guys think of? What age would you start thinking about it? Good, so this is news to people. 35. So here's the USPSTF guideline. Wow, I taught you guys something, thank God. So 35-year-old women with no personal history who have an elevated risk. And in the clinical trials, they use this Gale model. So they wouldn't make you parse that all out. I think they might give you a Gale risk score, though, potentially. I think that would be potentially fair game. So I would use a threshold of 3%, even though in the clinical trials use 1.66% in this 5-year model. The USPSTF has synthesized the data and said that people with a greater than 3-year risk of developing breast cancer should be on chemoprophylaxis. So this Gale model feeds in like family history, age of menarche, and other things like that. So I think as you guys see in MixApp, sometimes they just give you the answer or they tell you this is, it's SBP and what are you going to do for it? So I think in this situation, they would say this patient has a Gale risk, of 6% of developing breast cancer in the next 5 years. What is the most appropriate therapy? It's an online calculator, though, from NCI, I think. Why do we do it? Because it actually... I don't know why we don't do this more routinely in practice, to be honest. I've asked a couple of attendings in clinic, and they're like, oh, we don't really do that. But I don't know why. It's grade B. It's sort of hard to argue with that. The risks are what you guys know with using estrogen-type stuff. Obviously, they have some different effects on receptors. But again, VTE will be a problem here. And then this is just for your own like instruction, I suppose. So basically, this table comes from ACP Smart Medicine and shows that tamoxifen in all comers reduces the risk of invasive breast cancer by with a risk reduction of 0.5. But there's obviously risks associated with it. So that's how they define this threshold of like 3% 5-year risk. It's at that point that the risk reduction becomes even greater and supersedes some of the side effects with it, including other cancers. So it's treatment for 5 years. So I'll tell you what. Yeah, I know. So the guidelines say 5. I think that there's, this gets really specialized, but I think that like on the boards it'd be like, should this patient be on chemoprophylaxis or not? But that's I don't know. I guess some folks are shaking their head like they know. I mean, you may know more than I do.
The 10 years isn't
It's for after cancer. Chemoprophylaxis is 5 years. And you do it early, so you kind of make this dent up front, and I guess it's durable. So this says, yeah, all comers, but then it's outweighed in all comers by the risk of endometrial cancer, for example, with tamoxifen. And there's a little bit less risk of endometrial cancer with raloxifene. But the threshold of this 3% was set based on not just the trial data, but that's sort of like the threshold that the epidemiologists and biostatisticians decided was like the point of benefit. Clear benefit over harm. If they've had a hysterectomy, well, they can more safely be on it. I don't know if that's in the Gale model. I don't know if anybody knows. I'll just tell you that in high-risk women, it's something we should be doing, and I would think fair game to be tested. I wish I was an expert in it. I'm sorry. That's all I know is on the slides here. Once we got the slides, I'm gone. She's just as happy as she was before. This is the last slide. You guys know this stuff. All right, so all I'm going to ask is quickly diagnosis, treatment of each of these, and we're done. You guys can move on with your lives. Just treat presumptively for both. So I think that's fair. I think on the boards, like, you're not looking for gold standard tests on these things because the treatment of these things is so benign. BV, how do you treat it? 1 dose, 5 doses, 2 weeks. I have to remind myself here, actually. Trichomonas is the one you can give the single dose for. BV, you're supposed to do the topical for 5 or the PO for 7. And all I put on here is that they're all a little bit different for diagnosis. So technically, I mean, you could buy, Monistat over the counter, so it's clear that it's like safe to just treat this presumptively, but clinical history is not enough to definitively diagnose it, but I don't think they would test on that. BV is essentially a clinical diagnosis based on the criteria of grade discharge, the whiff test being positive, clue cells are high pH. And Trichomonas, we have this here, this is sort of a plug for our lab as well, that this actually, you can do a urinary PCR too, and it's super sensitive and specific. So that's now become the test of choice, especially if the wet mount is negative. Thanks for sticking with me. I know it's Julian's favorite topic, but any questions on any of that? Helpful, unhelpful? Don't worry, you're getting like real doctors that are going to do the rest of these. So, thank you. Friday we'll do questions though. Thank you. Friday we'll do questions though, and I think that'll probably be Maura or Eileen. So you guys get a break from me for a while.